Test 1 2 3 1 2 3. Test test test. stay behind the podium. There you go. If you move off, I'll point you back over.
I'm going to go ahead and get started. I just have a few introductory comments on sepsis, and then Debbie Whisenot's going to go through the latest slides on the Sepsis Initiative. And I've asked Lisa for a day in January for us to bring this back to you. This is obviously a work in progress. You're going to be hearing a lot about it. We're going to be learning a lot about it and sharing it with you. As we prepare to move forward with this Sepsis Initiative, I decided I wanted us to begin by taking a look back as we go forward. If you read about the history of sepsis, you're going to go all the way back to Hippocrates. As you know, he is the founder of medicine as a rational science. And he really solidified some concepts way back when that I think we're still using today, possibly under another name, but I think we're definitely still using them. Leanne autocorrected this when I gave her this slide, but he actually had sort of a yin and yang, pepsis and sepsis concept. And for Hippocrates, pepsis, or as I think of it, homeostasis, was the orderly, balanced, and harmonious digestion and metabolism of the four humors, which is essential to good health. And I think if you are familiar enough with homeostasis, with pepsis, then you should be able to recognize patients with sepsis even more quickly. At least that's the hope. He defined sepsis as the process by which flesh rots, swamps generate foul airs, and wounds fester. And I think that's something to remember as we move forward, just so that we know how concepts of sepsis began and changed over the years, and how our approach to sepsis and the patient with sepsis is changing. If you move forward in history, after the confirmation of the germ theory, people assumed that sepsis was the result of the host's invasion by organisms that were pathogenic. I lost the mic. Is that an issue? Can you hear me?
It's not amplified.
I'm going to keep going. Sepsis was assumed to be the result of the host's invasion by pathogenic organisms that spread in the bloodstream. Debbie, I hope you're ready to holler because I think I broke the microphone.
Never mind, she's got some new batteries.
All right. Once antibiotics were developed, we saw that patients frequently died in spite of successful eradication of the inciting pathogen. And because of this, we finally figured out that it's the host and not the pathogen that drives sepsis. In other words, we keep throwing antibiotics at people when ongoing bacterial replication is not the issue. It's the cascade of events that has been set off by those organisms. And that has led us to our definition of sepsis, which currently is a dysregulated immune response to infection, which can lead to tissue damage, sounds like I'm back on, organ failure, and death. And Debbie, I think that's my last slide before I turn it over to you. Actually, no, I've got one more. Because of the serious complications of sepsis, we've got a new initiative coming out. We really want to impart an appropriate sense of urgency. We want to standardize treatment, and we want to improve patient outcomes. And that was my last slide. I'm going to turn it over to Debbie. She'll go through the current slide set on the Sepsis Initiative, and I'll stick around for questions at the end. Thank you.
There you go.
Can I do it like this? Okay. Thank you, Dr. Middlebrooks. Well, I'd like to first say thank you for allowing us to speak to everyone today about this very important topic. Sepsis is something that is rampant across our country, and in our hospitals here in Alabama, we want to really make sure that we are working to do the right thing for our patients so that we can decrease this mortality here. Bear with us, we've got to get to the other set of slides. Lisa, this is not allowing it to go to a slideshow. Hold on, let's see. Here's from the beginning. Let me try that. It was a whole separate presentation.
There's something about the way.
Are they seeing it right?
They're saying it right.
But I can't. I have to be able to see it. Different current slides. See if they'll- no way.
So what do you need? Is this big enough or?
Sure. But I mean, how do I advance it?
I should have checked this. It's not.
See if they'll let me advance them.
Yeah. So all you gotta do is hit the down button.
But we're not doing the video. I don't know if it's not the same one.
Anybody a PowerPoint guru?
I know how to use PowerPoint, but it's
There's gotta be something in the way that it's.
close it and open it back up. Okay.
I'm gonna pull it back up. I'm glad they're not seeing everything while we're doing. So still doing it.
All right, we'll just see if they'll go to slideshow. I can do that. That's fine.
That work?
Okay.
Then either just maybe click on that or.
Mm. Okay, I think we're back. Did y'all enjoy the intermission? So sorry. Okay. Everybody loves technical difficulty. So you're seeing something a little different than I'm seeing. So y'all bear with me as I try to advance these slides. But anyway, so what we're going to talk about today is the initiative that we are doing alongside Ascension. So the Ascension Way, Leading with Quality and Safety, Surviving and Healing After Sepsis. So this is the initiative that we are going to be participating with over this next fiscal year. So fiscal year 19, this is one of our most important scorecard initiatives that we've had in a long time. And so over the course of this next year, we're going to be working with Ascension and then with Ascension, Alabama, which is all of our hospitals here locally, St. Vincent's Birmingham, St. Vincent's East, St. Vincent's Blount, St. Vincent's St. Clair, St. Vincent's Chilton, and now we welcome our Providence Health System as a member of Ascension, Alabama. So all of us working together, we're going to be able to survive and heal after sepsis and save our patients. So our calling is to reduce sepsis mortality, and so we need to understand that anyone can be affected by sepsis. This is not just about the really chronically sick person who comes into the hospital and has sepsis. Any young person can develop sepsis, a middle-aged person can develop sepsis. You can have a perfectly great vacation for a week, come back home and suddenly feel ill and have a little bit of a change in your condition, go to the hospital. Within 12 hours you could be in very serious condition from sepsis. We know this because this has happened to some of us in this room. We've had family members, but also we had a very dear person that worked within Ascension that happened to her. And so this is she is really being very integral in this pursuit that we have in trying to reduce sepsis mortality. So at Ascension, and we're talking over 120 hospitals, so at Ascension, sepsis cases accounted for approximately 35,000 discharges last year. Approximately 10% of the deaths that occurred in Ascension hospitals last year were due to sepsis. 6% of all U.S. hospitalizations are because of sepsis. And 1.7 million sepsis cases nationwide and 270,000 deaths occurred in 2014, which is some of the latest information that's out there in the literature. So with this work with Ascension and with Ascension, Alabama, we are having a large multidisciplinary effort to mobilize and to pull together quality, safety, and engagement and work together to advance the work that we're going to be doing on sepsis. So how are we going to be working together? So with One Ascension, we have a huge national group that's made up of the folks on the left, and you can see there's lots of different multidisciplinary committees. There's physicians, there's nurses, there's ancillary folks working with us, pharmacists, anybody who is clinical is working with us on this initiative. And so with this sepsis team nationally, we are working within our ministry market. So Ascension, Alabama is the ministry market that we have here locally. So we've developed an Ascension, Alabama sepsis mortality team where we are working collaboratively with folks in those disciplines we mentioned across 6 hospitals. We will have many monthly meetings. We have subgroup meetings that we're having, and all of this is to work around what we can do to improve our processes and outcomes of care for sepsis. And with that, each month we have a meeting, and as do other ministry markets, but we will be having meetings with Ascension where we go over what we are doing, what our successes are, what are our obstacles, what are the things that we know we need help from a national level. We have a new electronic medical record. Everybody knows OneChart, right? I know. And so there are a lot of tools that we can use within OneChart, but there's also a lot of our tools that have been developed that are paper processes that have actually still proven to be the best way to do our communication among our caregivers at this moment. So what are our objectives? So our objectives are going to be to improve the process of preventing, identifying, and managing sepsis. And so we're having to look at the process and the outcome goals. So we're going to have improvement in early sepsis identification and recognition and improvement in sepsis care bundle compliance. So you know we've been following the core measure sepsis bundle now for about 3 years. And with that, it's required by CMS, and it does include the 3 and 6 hour sepsis bundles. We have had some pretty good results, but then as we have moved forward, we kind of have our ups and downs in terms of compliance with that. But with this new effort, automatically we're going to see some improvements in that because it is looking at processes and outcomes. So for our outcome goal, we need to have a reduction in unwarranted care variation in managing sepsis, and also we will have a reduction in our mortality for the adult population with sepsis. So how are we going to take on sepsis the Ascension way? So if you look at the slide, you will see that we're going to have reliable early detection. We're going to implement the treatment bundle for the persons who come in with sepsis. We're going to reduce unwarranted variation in managing sepsis, and we're going to prevent hospital-acquired sepsis. So how in the world are we going to do that? So together we're going to take on sepsis, but we're going to also include our families and our patients in this process, because that is one of the most important things we can do, is listen to our patients, listen to our families. So the engagement and involvement of persons and families is going to be at the heart of what we're doing here. The person at the center of everything we do is the patient. So the patients, families, and all the folks around them are going to be vital partners. So this is a case about a patient that's a good scenario, and unfortunately, I'm going to have to ask someone else to read it because I can't read it on my slide. And I have to stand in front of the podium. So Lacey, can I ask you to read to us about Mrs. Smith and her journey with sepsis?
Sure. Mrs. Smith has end-stage renal disease and receives hemodialysis 3 times weekly. After returning home from her latest dialysis session, she tells her husband she is just not feeling well. She reports feeling chilled and short of breath. She seems a little confused. Her husband takes her to the emergency department where she is diagnosed with sepsis and possible pneumonia. She is admitted to the medical unit after a sputum culture is taken and a broad-spectrum beta-lactam antibiotic is initiated. Mrs. Smith does not show clinical improvement after 2 days, and blood cultures are drawn. The blood cultures grow, methicillin-resistant Staphylococcus aureus and vancomycin is initiated. She is diagnosed with a dialysis catheter-related infection. Unfortunately, Mrs. Smith continues to deteriorate and passes away on her 6th day of hospitalization.
So what are some of the lessons we've learned from that, Lacey?
Correct diagnosis and compliance with the sepsis bundle, including obtaining blood cultures, may have saved Mrs. Smith's life.
Okay. We have many stories like Mrs. Smith that we can tell you from our hospitals that since we've been working with this project and having a big focus on sepsis. And I know many folks listening and people in the room can also be able to write an example of a case similar to this. So as we move forward, hopefully we can have a better ending to some of these situations. So our teams are going to work together. We're going to use high reliability. We are a high reliability organization, so we're going to utilize our high reliability principles and also our safety behaviors that we've learned. And we will have, as providers and associates, a consistent voice and active role. We're going to utilize our leader rounding, our daily huddles. We're going to utilize our handoff tools. And so we're going to have an extreme focus on communication among the caregivers. And the better we communicate, the better the information we receive to use to treat our patients. This is sort of a busy slide, but the point of this is that we have to engage the whole care team in the management of sepsis. And so we talked just a minute ago about leader rounding and our daily huddles. So what we have on our nursing units and in our clinical departments is a daily management system, and we have a performance board where we put information that are on the vital few or the things that we are focusing on, sepsis being one of those, infection control being another, where we put our performance and our processes compliance and also our outcome compliance. And so daily huddles are held around these performance boards in these departments each day prior to the leader huddles that are held at each hospital, so either in the morning or mid-afternoon, whatever times these are done. And so the intent of this, when we have these daily huddles, and the leader huddles, is to talk about which patients are at risk. Do we have patients that have Foley catheters? Do we have patients that have central lines? Do we have patients that are immunosuppressed? Any of the patients that may be at high risk, we talk about those patients each day anyway, because we're trying on a daily basis to decrease the use of our devices. So if we can take them out, we want to talk about it, get the information in there, and that nurse taking care of that patient can either remove or talk to the doctor about removing any of the devices, okay? So that's how we incorporate our leader rounding and our associate rounding each day. And so if we identify these patients, we want to make sure that are we doing the things that we know are put in place for making sure that we can try to prevent these patients from having further injury. So the 3 and the 6 hour bundles, we have new posters that we're going to be putting up on all of our nursing units that they can put on their performance board that talks about the signs and symptoms of sepsis, and it also talks about what we do when we have those patients present with those signs and symptoms, or if they develop it while they're in the hospital. We talked a little bit about our multidisciplinary team that we have in place. And again, this team is made up of many, many disciplines. We've got physicians, Dr. Middlebrooks is a part of our team. We've got other physicians representing our other hospitals. The emergency department is a key focus because that's where about 85% of patients present with sepsis. The other 15% are hospital acquired, unfortunately, but we have to have representation from all these folks that you see listed on this wheel. And that person in the center is our patient. So all of the folks working in those departments represented here, centered around this patient, is how we will work together as a team. These next few slides are talking about some of the things that is in our toolkit that has been provided to us by Ascension. As we put together our teams, we had many folks that are required members of this team, and these few slides will talk to you about some of the responsibilities and roles that these folks have. So at the top of this list is senior leaders. So you think, okay, so what do senior leaders bring to the table? So you know your chief medical officer, your chief nursing officer, chief quality officer, and then the whole administrative team. So you ensure local support for the initiative. They're the ones that can listen to us as we tell them what we need. They engage the leaders across the organization. They help build capacity for the work by identifying additional resources that are needed. And then they help to evaluate the outcomes and request accountability of the different stakeholders. So they help us be able to do what it is we need to do and to move forward within our organization. The most important role here outside of the patient is that of the physician. And so what we ask of our physicians here is to maintain a high level of suspicion that sepsis could be behind a patient's decompensation. And again, remembering patients don't often present with very serious symptoms. Sometimes they're very subtle. So look for acute changes in vital signs, lab results, or their mental status. As we talked earlier about one of our leaders that works within Ascension, that was the first signal that her husband had some other things going on. His total mentation changed. And she noticed that and alerted the physicians to the fact that he had a change in his mentation. We want to evaluate all admitted patients for appropriate diagnosis. Any changes in the condition for inpatients suggest the therapy based on if we see that there's a suspicious infection or organism. We partner with nurses, pharmacists to care for the persons diagnosed with sepsis and try to adopt and use standardized processes and protocols. Reducing the sepsis risk, this is where we talked about we need to decrease our devices that we use. If a patient has a risk of aspiration pneumonia, then we want to make sure that we keep that on high alert as well. And listen to and acknowledge the voices and concerns of persons with sepsis or septic shock, and listen to their families. The specialty physicians, we'll just say here, some of the most important folks related to this are going to be emergency department physicians, because oftentimes they're the ones who see these patients first. And this is where they are going to be implementing that sepsis care bundle initially. They partner with nursing to have effective processes and ensure timely disposition to the ICU of those patients if that's where they need to go. And also that communication being so very important in the emergency department between the physician, the nurses, and then those same folks with the people that are receiving the patient in the other unit. An intensivist, this is going to be someone who follows through on the implementation of the sepsis care bundle and adjusts care as needed, either in the ICU or the non-ICU. Hospitalists are going to evaluate patients for the appropriate diagnosis, assess any changes in the condition, and then adjust the therapy. Infectious disease physicians identify the source of infection and adjust antimicrobials, and then the surgeon can help with source controls. And then from an infectious disease standpoint, and Dr. Middlebrooks can certainly elaborate on this later, is when we're talking about early recognition and diagnosis of sepsis, you know, one of the most important things too is if you need your infectious disease doctors and consults happen, we have to be timely with that. And you know, the phone call needs to go to to the specialist by the attending physician so that we can get rapid turnaround of the treatments. Nurses. Nurses are all over the place here. Nurses are the ones who are with the patients 24/7. So they act as early responders in identifying any changes in a person's condition. And they alert the team members. We have to remember our high reliability principles, our reluctance to simplify, listen to the patient and the family voice. We're going to reduce sepsis risk because we're going to try to take out devices when they're not needed, and we notice any change in that patient's condition, we escalate that to the physician. Promote the use of these standard protocols. So in those protocols that we have, it also includes protocols for nursing. Engage lab, make sure the workflow is efficient related to the lab testing. Some of the most important things that we can do are we get those blood cultures before antibiotics are done. We make sure that the lactic acids are drawn, and then if they have to have a repeat lactic acid in 2 hours, we have to make sure that we're staying on top of that clock because it's ticking every time when we do something for this patient. The leaders for the nurse managers and also other clinical leaders for those areas listed there, it's the same type of thing. Everybody just has to maintain that accountability. And pharmacists are very key to this process. They're going to help prioritize the delivery of the patient's medications for sepsis and septic shock. They work on plans with the providers to de-escalate the therapy when a clear diagnosis is made. And then they're also looking at clinical decision support utilizing our tools such as Century 7 to ensure follow-up on the rules pertinent to that antimicrobial stewardship is done and is appropriate. There is a pharmacy commitment that they're going to participate with rapid response if that is needed. Upon identification of a patient with sepsis, ensure that the antimicrobial therapy is based on the suspected source and initiated stat, and that the antimicrobial dose is appropriate based on the person's organ function. So the pharmacist plays an extremely important role in this. They're going to also facilitate the pressor therapy initiation based on our standard order parameters and complete daily prospective order review to make sure that the antimicrobial therapy is correct. And then if there's any dosing adjustments that need to be made based on the patient's care, then they will do that. So what are some of the new definitions? New bundle and a renewed urgency. So, we know that for a long time there's been lots of different definitions for sepsis, and so after much review it has proven that there needs to be just 2 definitions for sepsis. So sepsis is defined as a life-threatening organ dysfunction due to a dysregulated host response to infection. Sounds like Hippocrates was on the right track, Dr. Middlebrooks. Septic shock is a subset of sepsis in which underlying circulatory and cellular or metabolic abnormalities are profound enough to substantially increase mortality. We see a lot of patients, especially the hospital-acquired, that are jumping right into septic shock. So the terms severe sepsis, sepsis syndrome, and septicemia were deemed redundant or overly narrow and are not included in these new definitions. So where these new definitions come from, you can see the footnote at the bottom where these were adjusted by the European Society of Intensive Care Medicine and the Society of Critical Care Medicine in the 3rd International Consortium definitions for sepsis and septic shock. This slide, and it's in your packet, there was some literature that was out there that was released, and this information was put in the slides related to surviving sepsis and moving into hour 1. In the last couple of weeks, the Critical Care Consortium and some other folks have adjusted this and have asked to pull this back for now because they want to look better to see how they can further define what's going on in that first hour and the ability to be able to make some of those things happen. Recognizing that it is very difficult to do a lot of these things within 1 hour, the objective right now is going to be to stick to what we're doing right now within our early recognition and have those 3 and 6 hour bundles be what's in place. The main focus of all this is early recognition, and so that's what we want to focus on instead of just saying 1 hour. There'll be more to come on this, but that's just kind of an editorial. So if you've got a packet and you want to just put an X through that, you can. So along those lines, we want to say, be ready to ask, could it be sepsis? How do we spot it early and save a life? So we have early detection of sepsis is critical. Prompt treatment gives the person their best chance to survive. Signs and symptoms of sepsis are not always clear. We want to maintain a high level of suspicion that sepsis could be behind any acute changes in the condition, especially those people we talked about earlier that are at higher risk. And be vigilant in watching for changes in a patient's condition, knowing that an altered mentation can be an early warning sign, especially in the elderly patient. Also, going back to reiterate what we talked about earlier, our persons and families are vital partners in this process. We want to listen with empathy to make a human connection and truly hear the voices of those we serve. You know, it's a very busy world that we're all trying to practice healthcare in each day, but spending those few extra minutes to listen not only to the patient, but to listen to their family's concerns. You know, oftentimes if a patient's just been admitted and they're very sick and they've got a spouse or a child with them that takes care of them at home, they're the ones who know more about that family than certainly we do in the beginning. And so it's very important that we learn to listen. And family members are the experts. You know, they know what works for their family member. So encourage family members to speak up and work with these families as a team. So how are we going to reduce mortality in fiscal year 19? So first of all, we want to reduce sepsis mortality by 10%. That's the Ascension goal. Within our Ascension, Alabama market, we have a goal of reducing sepsis by 5.7%. So Ascension has a 10% goal, and then the different ministry markets, based on the performance of where we are current state, determines what our goals are. So if we can reduce mortality by 10%, remember that 350,000 we talked about earlier, we can save 350 lives. So to do that, we have to improve our clinical process reliability and promote appropriate utilization of these order sets that we've talked about. So what if we could save 350 lives? The loved ones of countless family members and friends, maybe even someone you love. This is kind of a cool slide to me because that's multiple people's faces. So these are the faces of sepsis. So we talk about on a national level, and I will tell you also at this Ascension, Alabama level, we have got standardized order sets. They've been implemented in all the electronic health records. And I will tell you at Ascension, Alabama, we know that there are some issues with some of the, like the Sepsis Advisor order sets and some of those things. It has been escalated all the way up with the One Chart team, and they are working on some of those things for us. So that our hope is as we continue to improve these standardized order sets that we are able to use, that we'll be able to decrease the variability there. So we've got a robust sepsis education program that's in place. There has been a My Learning developed that is going to be pushed out to all clinical associates, and we will be communicating that in a different venue for physicians. But this will be on the My Learning, and it's required by the end of December. So y'all will be getting an email that tells you that you need to go out there and take that. Some of the other things we're doing is we've been going to our different medical staff meetings. We're doing CMEs. We have posters that we've just received from Ascension that will be being put up. We have badge buddies that are going to be ordered that folks can have around that talks about the signs and symptoms. The order sets that are out there, they are really good. We've got the Sepsis Advisor, we've got ED power plans and medical power plans that if you have not seen them, at least go in there and look at that. But if you're not using them, then make sure that you are doing what is in those power plans for your patients. We do have a sepsis toolkit that addresses sepsis in a holistic way that's giving us some guidelines that we are following for this. The sepsis toolkit, it told us how to build our team. So this big multidisciplinary team we have, made up of representatives from all over our health system. Reliable early detection, implementing the treatment bundle for persons with sepsis, again, reducing the unwarranted variation and preventing hospital-acquired sepsis. I repeat that because that is the thrust of what it is we've got to do. So our first steps as a ministry market. We have our ministry market team led by the Chief Quality Officer and representations from all the different facilities as well as disciplines across Ascension, Alabama. In this toolkit, it's going to help us identify how we partner, how we communicate, and what we need to do in terms of putting that message out to everyone who can help us in this initiative. So the ongoing action for our ministry market leaders and teams is we're going to reinforce the message, the urgency of improving sepsis outcomes. We're going to talk about it in every opportunity we can. Huddles, medical staff meetings, the general medical staff meetings that will be held this fall. We're going to have parts of that to be focused on sepsis. As Dr. Middlebrooks mentioned, in January we'll have another CME here where we're going to talk more about what we have identified and what we've learned and what we've been able to do to improve here at our health system. We're going to hardwire mechanisms for early identification of sepsis. Some of the ways we're going to do that, we're working with our rapid response teams. We have representation sitting on a national team for rapid response to talk about what are some of the things that they can do to help improve. One of the main things is to have protocols for sepsis identification as part of the protocols that are included with rapid response, and to have action plans in there on how they would treat the patient. Promote adoption of Ascension standardized order sets, reduce risk of infections by continuing to do what infection control, and Dr. Middlebrooks is working with us continuously now with decreasing our devices. Engage the rapid response teams, like I mentioned, and also connect teams to the resources of high reliability, the daily management system, and then aim for excellence. So we had a kickoff meeting back in early August. We've had 2 meetings in terms of our Ascension Alabama group. We met with a Ascension Alabama team, had a meeting with the national team on Friday. We have identified where some gaps are across our health system at the different hospitals, and we have a lot of action plans in place already, and we're about 45 days into this project. They will visit the ministry markets who have some of the highest opportunities, and I will tell you that we do have some opportunities. Observed over expected is one of the ways that we look at sepsis mortality, and that's a risk-adjusted way to look at your mortality. So we are working with our coding teams, our CDI teams, our physicians, our nurses to make sure that we can get all of the things documented so that we can code these appropriately. So what could we do if we reduce sepsis mortality by 10%? So if you see Ascension, Alabama in there, you can see that that would be 34 patients' lives that we could save within our 6 hospitals. So in conclusion, our goal is to improve patient outcomes while reducing sepsis mortality by 10%, or like I said, at Ascension, Alabama, 5.7%. So how are we going to achieve this? This will be through education to our physicians, our associates, our whole clinical staff, having our multidisciplinary team in place to help push forward some of the standardization that we have, improving our clinical process by order set standardization, and then being very collaborative in our approach. Thank you very much, and we will entertain any questions you may have. Dr. Middlebrooks is available to answer those. So, any questions? Okay, thank you so much.